Hello.
Hello. Yes, now it is audible. I hope now it will be audible. Yes. What about now? Yes. So I think now the voice is audible, and let's get into the session. And welcome you all, my dear Plan MSc 5.0 subscribers. I welcome you all to the another important probable MCQ discussions of your community health nursing and nursing management. So just today the final registration and everything was closing, and you people were receiving the final call for the payment and all. Hope everyone has done your registration and all the process in the smooth manner. And today at 5 p.m. The registration is also completely closed, and all the work related the application of your AIMS MSc entrance examination has been closed, and now you are stress free, and this is a very good time to have a class, right? So now let's get into the session. And how about the preparation is going with your Plan MSc 5.0? Is the preparation is going well? I hope it is going well, and since the exams are approaching so soon, be very cautious in your preparation. Don't waste time. Stay motivated, stay confident, and prepare well. So now let's get into the session. And good evening once again everyone, every children who is messaging me in the chat box. And now let's get into the session. So today first we are going to see community health nursing's MCQs. So before going into the MCQs, I would like to reinforce some of the important points that you have to definitely take before going for the competitive examinations of nursing. So for AIMS MSc entrance examination, this particular components are very, very important. Those components are pooled and the MCQs are developed, and we are going to see those MCQs in this video. So the first and foremost thing we are going to see about the National Family Planning Program. Under that, we are not going to see everything, the most important concepts under that. Right. The first is the intrauterine devices. The intrauterine devices. As you all know, you know about IUCD. What is meant by IUCD? What is meant by IUCD? As you all know, it is not intrauterine copper devices, it is intrauterine contraceptive devices, as you all know. So now we are going to see in detail about these intrauterine contraceptive devices, because image based questions are coming from that. What is the composition of that? What is the when it has to be used? So many components like that are coming in your competitive examination, so we are going to see about it. So first and foremost, I would like to reinforce like the IUCDs, the intrauterine contraceptive devices, has 3 generations. The first generation, second generation, and the third generation. As you all know, the first generation are termed as inert IUDs, that is inert intrauterine devices, and the examples of these first generation intrauterine devices is Lippes, loops, and your Grafenberg's ring. So these are outdated and not currently in the practice. These particular first generation intrauterine devices are outdated and now they are not in practice. So next you have the second generation, the most important generation among all the generations, and these devices are the devices which came with copper containing IUDs. This is the innovation which is made from the second generation. The intrauterine devices is infused with the copper material, right? So the best examples of your second generation intrauterine contraceptive devices is your CUT, copper T200, copper T380A, and copper T375 multi-load. In this, the very important point to note is your copper T380A and the copper T375 multi-load both are used in your National Family Planning Program. So these both are used in your National Family Planning Program. So this is very important to note. Okay, they are used in the family planning programs. Am I audible now? What happened? Okay, now am I audible? Everything is going clear, right? Yes. So as I said you, in second generation, the most important generation, these are copper containing intrauterine devices. In these devices, your copper T200 and copper T380A and copper T375. Now voice is clear? Now voice is clear? Please let me know. Now the voice is clear or not? Yes. Okay, fine. So in second generation, as I said you, these are copper containing intrauterine devices. In this, the most important thing you have to notice, your copper T380A, your copper T380A is under National Family Planning Program, and your copper T375A is also under your National Family Planning Program, right? And the most important thing, the other thing what you want to know is what is the other name? Do they have any other name? Your copper T380A is otherwise known as your Paragod. Paragod. This copper T380A, okay, your copper T380A is otherwise known as Paragod. That you just have this information, okay? Next you are going to come to the third generation. The third generation are copper plus hormone induced. Okay, sorry, not copper, it is hormonal IUDs. Like these intrauterine devices are infused with hormones such as progesterone and all, right? So if you see what are the examples of third generation copper intrauterine devices, that is your Mirena and your progesterate. In this, Mirena is also used under your under your National Family Planning Program. So this is very important to know, like which particular components, which are all the examples for each generation. As I said you, in first generation they are inert intrauterine devices. They have Lippi's loop and your Grafenberg's ring, and these particular components are outdated or not now used in practice. In the second generation you have copper T200, copper T380A and multi-load, that is your copper T375 multi-load. These are coming under your second generation intrauterine devices. These are infused with the copper materials, okay? The third generation you have your Mirena and your progesterate. These are hormonal based intrauterine devices. This is very important to know about all the three generations of copper T, right? Intrauterine devices. So now the very important slide, you have to give more attention to it. So what is the difference between your copper T380A, that is your Paragod, versus copper T375? Okay, both are used in the National Family Planning Program and advised for the females. So what is the major difference and what is the important component? And this is a very, very important MCQ part, right? So first, copper T380A. As you can see, the copper T380A is T-shaped. As you see here, it has T-shaped, right? It has T-shaped. And you see, it has the name A, 380A. What is meant by A? A means on the stem and arms, which means the copper is present in the stem and in the arms. The copper is present in the stem as well as in the arms. Why 380 was given? 380 means that is the millimeter square. Okay, the millimeter square, the surface area of the copper is termed as this 380A. So 380 millimeter squares of copper surface is surrounded in this copper T. That's why it is termed as copper T380A. Why A is there? Because the copper is encircled in the arms also. The copper is present in the arms also. So next is the lifespan, the most important question again. The lifespan of copper T380A is 10 years. Very, very important point to know. The lifespan of the copper T380A is 10 years. So now the voice is clear. See, please check your internet if the voice is not clear, right? If there is an issue in the audio, please let me know through the chat, okay? So first is, as I said the surface area of the copper is 380 millimeter square. That is why it is named as copper T380A, right? So now you have to note the thread. As you all know, for the woman who is inserted with intrauterine devices, the confirmation that device is under the uterus, inside the uterus, the confirmation we will do with the help of this thread. When she is bathing, when she is having a self-care, when the patient is already inserted with an intrauterine device, she has to examine by leaving her hands in the vagina so that she can able to see these two threads which is coming outside the vagina, right? This means the intrauterine device is in the place. If this thread is not visible, she has to immediately report to the medical people so that to get the further evaluation of the misplacement of the copper T2, right? So next we are going to come to the copper T375 multi-load. Okay, so this copper T380 is T-shaped, and you should be very, very clear. Copper T375 multi-load is having umbrella shape or U-shape. Umbrella shape or U-shape. Umbrella shape or U-shape. And what is the lifespan of copper T375? With the copper T375's lifespan is 5 years, whereas for your copper T380 it is 10 years. Please have the comparative learning so that you can able to have better understanding. Next, the copper placement, as you can see, in copper T380 the copper placement was there in the stem as well as the arms, whereas here you can see only the stem is going to have the copper. Only the stem is going to have the copper. Next, the thread which is propelling, which is outside, which we are using for the confirmation whether the copper T is in the place or not, it is made up of monofilament nylon, blue or green thread in case of 375, your copper T 375. In case of your copper T 380, it is a polyethylene thread which is white in color. So on examination you can find whether the patient is having copper T380A or copper T375 multi-load. You can able to understand in this, right? So next, the surface area of copper present in multi-load 375 is less than 380 mm per square. Okay, less than 380 mm per square. So the most important thing you have to note again here is the mechanism of action. What is the mechanism of action of the second generation intrauterine devices? So the most important question they will be asking in your examination, what is the primary mechanism, what is the secondary mechanism? The primary mechanism of action is, what is the primary mechanism of action? Anyone can answer me? What is the primary mechanism of action? It prevents fertilization. It prevents fertilization. It prevents fertilization. And what is the second most important mechanism of action? That is the secondary mechanism of action is, it prevents implantation. Okay, it prevents implantation. It prevents implantation. So these are the most important components you have to note in the mechanism of action. And one more thing you have to note is, like how it is preventing fertilization, how it is preventing implantation. The first and foremost thing, right? As you all know, this copper T will be inserted inside the uterus of the female, right? So once it is inserted inside the uterus of the female, this copper particles will be identified as a foreign particle and the uterus will start getting inflamed. The inflammation of the endometrium will be taking place. This inflammation of the endometrium will make sure that it is not a compatible area for implantation, to the fertilization to happen, right? So this makes the implantation to become, prevents fertilization. Yes, Akshada, very good. The primary mechanism of action of your copper T is preventing fertilization. The secondary action of your copper T is prevents implantation. Okay, so when this inflammation process is taking place because of the foreign body of the copper, what will happen? It will not be a good media, it will not be a good base for a implantation, so that fertilization is not going to happen, right? So this is all about your mechanism of action of the second generation copper T, intrauterine devices. And what kind of action it is not doing? There is no effect. There is no effect of copper T. There is no effect of copper T on an ovulation. It has no effect on ovulation. Okay, it has no effect of ovulation. And the most important another one thing is, it will not act as an abortifacient. Abortifacient, which means it will not act as an abortifacient agent. So abortifacient agent acts after the implantation, but this is not the case. Same here. Copper Ts will be preventing the fertilization and preventing the implantation before it is having. When a woman is having active sex, so then we are going to opt her with the copper T. But abortifacient agents or something which is going to work after the implantation has occurred, right? So you should be very clear in these things. So first and foremost thing, the mechanism of action. If they are asking what is the mechanism of action of second generation intrauterine devices, or they are going to give the specific name of copper T380A and copper T375 multi-load, you are going to tell it is preventing fertilization. Then if fertilization is not there in the option, the second best answer will be preventing implantation. But these two devices, that is the second generation devices, has no effect on ovulation. It is not inhibiting any kind of ovulation, and it is not having the abortifacient effort also, right? And to understand, to have a better remembering, this multi-load will have an umbrella shape, as I said you, and it has spur, right? These projections, these tiny projection is termed as spur. So what this spur is doing? This spur is making the device to sit in the place. Okay, this spur will reduce the accidental what happened? Voice not clear. Does the voice is clear now? Please check your internet. Accidental removal, okay, accidental removal or misplacement can be reduced because of this spur which is present in the multi-load copper T. So the next we are going to see the next important component. Now we are going to see about the third generation intrauterine devices. So second generation we have completed, that is your copper T380A and your copper T375, that is multi-load. Now, voice is not clear. Once again. Is it audible now, children? Is it audible now? Is it audible now? Palabi? I think it's audible now. confirm the same. Is the voice audible or not, dear children? Please tell me. Akshita, tell me, voice is audible or clear, or it is breaking, so that we can make necessary changes. Yes, is audible. Okay, fine. So next we are going to see about the third generation intrauterine devices. The third generation intrauterine devices are hormonal IUDs, that is hormone infused intrauterine devices, or the third generation intrauterine devices. Right, as I said you, the examples of your hormonal intrauterine devices which is belonging to the third generation, they are Mirena and your progesterone. Right, I will show you the images of Mirena and progesterone in the next slide. So first we are going to learn what are the hormones which is present in each of these particular hormonal intrauterine devices. So Mirena is otherwise known as LNG20 because it has levonorgestrel. It has levonorgestrel. It is a form of your progesterone, synthetic progesterone, as you all know. So because of that only Mirena is having the other name of LNG20. Because of that only Mirena is having the other name LNG20. So it is having synthetic form of levonorgestrel, that is your synthetic form of your progesterone. And next, in case of progesterone, it is having natural progesterone. It is having natural progesterone. Next, the total hormonal load is 52 mg in case of your Mirena, and the hormonal load in progesterone is 38 mg. When comparing to both the cases, Mirena is very important to note. Please pay a keen attention, right? So total hormonal load is 50 and 52 mg, and here in progesterone it is 38 mg. And the most important thing, the rate of secretion. The rate of secretion is 20 microgram per day. That's why Mirena is otherwise named as LNG20, because it is releasing 20 microgram per day in your uterus. Next, here in progesterone it is releasing 65 mcg per day, and here the shape of the devices is T-shaped device. The Mirena is also T-shaped device, but you should be very clear in identifying the differentiation between your copper T 380A and Mirena. Right, so your copper T 380A is going to have copper, but in Mirena this is not the same case. So you should have that basic understanding, like what particular generation the each intrauterine device is coming under. Right, so next, the shape of the device here is also T-shaped only. Next, the lifespan of levonorgestrel, the most common and important MCQ point you have to remember, the lifespan of levonorgestrel, that is your Mirena, is 5 years. A very important point to note. Then the lifespan of your progesterone is 1 year, which is not that much competent enough. The thread which you are going to palpate on vaginal examination, and the woman is going to palpate for the correct placement or displacement of your presence of your intrauterine device, is made up of monofilament nylon, which is blue or green in color in case of your Mirena. In case of your progesterone, it is polyethylene white in color. It is polyethylene white in color. Next, the expulsion rate is also an important question to note. The expulsion rate of your Mirena is lowest among all the IUCDs. The expulsion rate of your Mirena is lowest among all the intrauterine devices. Next, the failure rate is also less. Since the expulsion rate is less, it is the common sense the failure rate will be also less. So the failure rate of Mirena is 0.3 per 100 women in a year. So which is a very less failure rate. So the most important question you have to note, which of the following intrauterine devices has the less expulsion rate or the less failure rate? Then your answer will be Mirena. Right, so what is the failure rate? If there is a question, you should be very clear that you have to tell 0.3 per 100 women per year. Right, so here in progesterone the expulsion rate is very higher when comparing to Mirena. Next, the associated risk if fails. See, listen, the most important point again you have to note here is, see children, all the intrauterine devices, there is a misconception that intrauterine devices causes ectopic pregnancy. No. Intrauterine devices has the risk of causing ectopic pregnancy. No. The correct statement you have to understand is intrauterine device failure. The failure of intrauterine devices can cause the risk of ectopic pregnancy. So that is the most important point you note. You should not like while the expulsion rate means like when the intrauterine devices is not placed inside properly and it comes out spontaneously, or it will be misplaced. For example, this is your uterus. So this is the uterus, this is how the copper T will be placed. When it is not placed properly in that particular place and it is coming outside spontaneously, or any misplacement like this, so this is termed as your expulsion. So if it is placed properly, then you can see the two threads which is coming out, which is confirming that the particular copper T is in place. So if it is misplaced, you cannot find those threads. So that is termed as your expulsion. Right? So next is the associated risk if it fails. The most important point, the most important word you have to notice, the associated risk factor if it fails. If it fails only, it will lead to ectopic pregnancy. So that intrauterine device itself is not a risk factor of ectopic pregnancy. That is what you should be very clear. If intrauterine devices is going to fail, it is going to cause ectopic pregnancy, but intrauterine device itself is not going to cause any risk for ectopic pregnancy. Clear, children? Next, you have the side effects. So it has the lowest side effects. Marina is having the lowest side effects when comparing to all other important intrauterine contraceptive devices. Right? So what is the important mechanism of action of your third generation intrauterine devices? Okay. See, I'm reading copper, intrauterine contraceptive devices. So what is the important mechanism of action of your third generation intrauterine contraceptive devices such as Marina and progesterone? The primary and the most important mechanism of action is what? It prevents implantation. It prevents implantation. So these are hormonal based third generation, or basically hormonal based kind of intrauterine contraceptive devices, as I said you. Right. So next, here is the clear image of Marina and progesterone. So this is Marina, the hormonal contraceptive. As you see, you have to able to differentiate when there is an image based question. You should able to clearly understand what is Marina, how Marina is looking, how your copper T is looking. So you can see there is no copper in arms or in the stem, only the reservoir containing levonorgestrel is there. The reservoir containing levonorgestrel, which is going to release 20 mcg, 20 microgram per day. 20 mcg per day, as I said you. So that's why it is otherwise termed as LNG 20. It is otherwise termed as LNG 20. Okay. So here you have the threads which is hanging and the centimeter. These are all not most commonly asked, but you can note as an additional. Voices. Okay. So let's start. So next we have progesterone. So this is the progesterone. If we are asking image based question, you can able to identify progesterone. So that is why I have projected the image of progesterone as well. And the next important concepts you are going to learn here is, when we talk about copper T, the most important side effects, see, since let me write here itself, you will have a better understanding. So I will use different color. So for your copper T, the most common side effect, okay, the most common side effect is bleeding and pain. The same in case of your hormonal contraceptives. In case of your hormonal contraceptives, that is third generation, the most common side effect is not bleeding. Okay, the most common side effect is irregular bleeding. The most common side effect is irregular bleeding. So what happened? This irregular bleeding, after few days, it will proceed to amenorrhea. Okay, it will proceed to amenorrhea. This irregular bleeding will be further proceed to amenorrhea. So that is why in cases where there is an increased risk of bleeding, increased risk of bleeding, in this case we are not going to go for copper T, we are going to prescribe third generation intrauterine devices, that is hormonal based devices. In case of the patient is not having such histories, then we will go for copper T. But if the patient is having the increased risk of, like already the patient is currently having pelvic inflammatory disease, the patient is having atypical uterine bleeding, in these cases we are not going to directly administer copper T because it is an absolute contraindication. But in those cases we can go for this hormonal contraceptive devices, right? So next, okay, so the most important next component they can ask, the possible questions they can ask under your intrauterine contraceptive devices is where you have to discard, in which the biomedical waste management, where you have to discard this intrauterine contraceptive devices. So discarding, anyone can answer me, like where you will discard this IUCDs discard according to biomedical waste management? Just tell me in which color you will be discarding. Yes, I'm just waiting for your answer. Like in which color you will be discarding the intrauterine devices? You will be discarding the intrauterine devices in red bag. A very, very important point to note. You are going to discard this IUCDs in the red bag. You are going to discard this IUCDs in the red bag. Okay, so I'm just highlighting like this so that you will not forget at all. Okay. So where you are going to discard, it is in red bag. Very good. Shahana Pal, bear with me, and Fatima, Palabi, Pativa, everyone. Very good. You are going to discard this intrauterine contraceptive devices in the red bag. So next, the timing of insertion of intrauterine contraceptive devices is also a very important point. So let's see one by one. First, when you are inserting during the cesarean session, that is termed as intracesarean intrauterine device insertion. During the time of LSES, when you are inserting, okay, immediately. So that is termed as your intracesarean intrauterine device implantation, right? So next, post-placental. Post-placental is within 10 minutes of the placenta delivery. Within the 10 minutes of placenta delivery. Post-placental is within 10 minutes of placental delivery. Next, postpartal. Postpartal is 10 minutes to 48 hours after delivery. 10 minutes to 48 hours after delivery. The most important point you have to note, what is the government of India's recommendation for the intrauterine device insertion? The most important point you have to note, the postpartum insertion of your intrauterine contraceptive devices is advised by your government of India. Right. So first you have to be very clear. Post-placental insertion is within 10 minutes after the placenta is delivered. Within 10 minutes after the placenta is delivered. Then comes the postpartum, as the name implies, from 10 minutes to 48 hours after delivery, that is 2 days after delivery, we are terming it as postpartum. This particular postpartum component is recommended by Government of India. So This is the important component you have to note. Next, if at all I cannot able to insert the intrauterine contraceptive devices after 48 hours, I'm not going to insert it. I'm going to wait for the next 6 weeks after the delivery, and then I'm going to insert. After 2 days, I'm not going to insert the intrauterine contraceptive devices. If at all it is not possible, I was not inserting the intrauterine contraceptive devices within 48 hours, within 48 hours, what I'm going to do, I'm going to wait for the next 6 weeks, and then only I'm going to place the intrauterine device. So that is termed as interval insertion. So you are giving the interval of 6 weeks, then you are going to insert the copper-T, because it is not advised to insert after 48 hours, right? So that particular 6 weeks, after 6 weeks of delivery, if you are inserting the intrauterine contraceptive device, that is called as interval insertion. That is called as interval insertions. So when we use these IUDs, I'm having a clear table for that also. You'll be learning soon. Just concentrate on this. Okay. So interval insertion is after 6 weeks of the delivery. Then post-surgical abortion, after 12 days of the post-surgical abortion, that is termed as after 12 days. Next we have after 13 to 15 days, post-medical abortion. After post-medical abortion, you are going to insert the copper-T. After female, you are going to insert within 10 days of the menstruation start. Like within 10 days, since the menstruation starts, you are going to insert this copper-T. So once more, we will review this table. So in case of intracesarean. What is intracesarean? When the copper-T is administered during the cesarean session, that is termed as intracesarean. Next, we have post-placental. What is meant by post-placental? Within 10 minutes of placenta delivery, if you are inserting, that is termed as post-placental. Next, we have postpartum, which is advised or which is recommended by the government of India. So that is 10 minutes to 48 hours after delivery. If I could not place the intrauterine contraceptive device after within 48 hours, then I'm going to wait for the next 6 weeks, and then only I'm going to insert this intrauterine contraceptive device. So that is termed as interval insertion, if I'm inserting it after 6 weeks. Next is in case of post-surgical abortion, I'm going to insert after 12 days. In case of post-medical abortion, I'm going to insert after 13 to 15 days. For non-pregnant female, what is the case of insertion? You are going to insert it within 10 days after the menstruation is starting. Right? Yes. This table is also very, very important. So next table, the important drugs which is coming under, and in all the competitive examinations coming under your family planning programs. First is your DMPA, which is commonly known as Antara, because in the family planning program it is named as Antara. Okay, it is named as Antara, commonly named as Antara. And what is the active component which is present in DMPA, and that is the expansion of DMPA? That is your depot medroxyprogesterate acetate. Depot medroxyprogesterate acetate. So what is the dosage of this particular drug administration? It is an implant kind of thing. So it is 150 mg IM. 150 mg IM. So gluteal IM is recommended. Next, the frequency, every 3 months you are going to administer with this DMPA, which is commonly known as your Antara. And the mechanism of action of your DMPA Antara is, it is a progesterone only pill. It is a progesterone only injection. It is an injectable implant. Next, what is the advantage and side effects? It has discrete advantages like decreased menstrual blood loss, good for anemic one. So all the progesterone only containing components, as I said, we have learnt in Marina, so it will cause irregular periods at first, irregular menstruation at first, and later it leads to amenorrhea, which is absence of bleeding. Same way, DMPA is a injectable progesterone only injection. So this is also going to cause you the menstrual blood flow loss. So that's why it is advised for anemic patients. So just think about it. Marina, we have studied Marina is having progesterone. Okay, progesterone hormonal component inside it. So what I said, you Copper T is going to cause increased bleeding, whereas Marina is going to cause bleeding initially, irregular bleeding initially, and after days goes on, what it is going to do? It is going to cause amenorrhea. So the same case is applied to here also, because it is also a progesterone only injection. So what it is going to do? It is going to decrease the menstrual blood loss. Initially the patient will be having bleeding, later she will be going for amenorrhea. So that's why this particular your depot medroxyprogesterone acetate is used in case of anemic women in order to reduce the blood loss. So what is the missed dose management? So first we have to give follow-up for 2 weeks. Okay, follow-up for 2 weeks before 2 weeks before to 4 weeks after due date. So no need for additional contraception. So once the patient is taking regularly, no need of any additional contraceptions in case of your depot. Next we have your NETEN. So it is your norethistérone ethanate, not norethistérone entate. Okay. Sorry. It is your norethistérone enanthate. It is your norethistérone enanthate. So the dosage of drug is 200 mg IM. 200 mg IM. Then it is going to administered every 2 months, and it is also a progesterone only injection. So it will be having the same advantage and side effects as like your depot. Okay, as like your DMPA, that is commonly called as Antara. Antara is your DMPA. You have to remember. Last NORCET 8.0 also had a question on Antara. Okay, so it is very important to note. So next we have your Centroman. Your Centroman is also a very important drug to note, because this is also involved in your National Family Planning Program. This was earlier known as Shelly. Okay, earlier known as Shelly, and currently we are terming it as Chaya. Currently it is termed as Chaya. Earlier it was named Shelly. Now it is commonly termed as Chaya. So Chaya is your Centroman. Okay, Centroman. So what is the combination or active component in your Chaya? That is your Centroman is your ormeloxifene. Ormeloxifene is the active component in Chaya. So what is the administration? 30 mg orally for bi-weekly for the first 3 months. 30 mg orally for bi-weekly for the first 3 months. For the first 3 months, every week 2 tablets will be taken by the patient orally, 30 mg tablets. After 3 months, it will be once. Okay, after 3 months, it will be 1 tablet per week. Clear? See, for the first 3 weeks, it will be 2 tablet per week, and for the next 3 weeks, after completing this course, for the next 3 weeks, it will be 1 tablet per week. Clear? Yes. So next frequency, after completing the first 3 weeks, 2 tablets weekly, then you're going for the next 3 months. For the next 3 months, you're going to go for, see, it is not weeks, please. Okay, fine. See, noted. I'm not confusing. Noted first. So for the first 3 months, so we are talking about Chaya. For the first 3 months, every week, okay, weekly you are going to give 2 tablets. Weekly you are going to give 2 tablets. So the first 3 months the course is over. For the next 3 months, what you are going to give? You give weekly only 1 tablet. Weekly only 1 tablet. Weekly only 1 tablet you are going to give. That is the concept between your Centroman, that is Chaya. Right. So 30 mg orally bi-weekly for the first 3 months, and next for the next 3 months it will be weekly once. 1 tablet per week for the next 3 months. Next. So next, so what is the mechanism of action of Chaya? You have to remember, it is not a progesterone component, It is not an estrogen component, but it is a selective estrogen receptor modulator. It is a non-hormonal and non-steroidal, a very, very important point to note. So when they ask you about the action, mechanism of action of your chaya, that is your centromen, you have to tell it is a selective estrogen receptor modulator. Selective estrogen receptor modulator. It is a selective estrogen receptor modulator, and it is non-hormonal and non-steroidal. It is non-hormonal and non-steroidal. Whereas in this case of Antara and your NET-EN, it is your progesterone only component. It is progesterone only component. So next we have LNG. Okay, sorry. We are going to see the advantages of your centromen. The advantages of centromen is it again causes menstrual irregularities, since it is having estrogen receptor modulator, selective estrogen receptor modulator. It is going to cause menstrual irregularities, mood changes, and hot flushes, because estrogen causes these kind of factors. Next, if chaya is missed, centromen tablet is missed, what is the management? If it is less than 7 days, take one, and also you have to use the alternate method. Take one tablet and use the alternate method. If it is greater than 7 days, you have to stop use and you have to use alternate method of contraception, and you have to restart the pack. You're not going to continue with it, you're going to restart the pack again. So first and foremost, you have to understand, if it is less than 7 days, take one tablet. Okay, whenever you remember, take one tablet, and additionally what you're going to do, you are going to have an alternate contraception also, in order to have a better contraception. Next, if in case you miss it, okay, in greater than 7 days, like more than 7 days, if you missed it after 7 days, so what you have to do, you have to stop the tablet immediately, and you have to start it from the fresh along with another alternative contraceptive method, right? So next we have LNG, the most common used drug in your emergency contraception. Emergency contraception is your levonorgestrel. So levonorgestrel is the most common drug which is used in the emergency contraception. So that is your LNG pill. That is termed as I pill, easy pill. Okay, it is the levonorgestrel. The active component is the levonorgestrel. As you all know, it is used as the most common used emergency contraceptive. So the dose and route of drug is 1.5 mg orally, single dose. So either you can administer the drug in 1.5 mg orally as a single dose, or you can split the dose into 0.75 mcg and 0.75, and you can give after 12 hours. Like initially you will be taking it, and after 12 hours you are going to take another 0.75 mg, right? So next you have, it's not mcg, it is mg. Okay, so make it very clear. So first, if the patient is, you can also administer this 1.5 mg single dose into splitter dose, that is you are dividing into 0.75 and 0.75. So initially you are giving after 12 hours. After 12 hours again you are going to administer another 0.75 mg, right? Another 0.75 mg. Next, this particular drug, LNG, emergency contraceptive levonorgestrel, has to be administered within 72 hours post intercourse. Within 72 hours post intercourse, but it can be administered, its action can be until 5 days, but it is not proven. Okay, it can be used till 5 days, but it is better to take, the efficacy of the tablet is more good when it is taken within 72 hours, that is 3 days. So next, it is an emergency contraceptive, a very, very important point to note, and the effectiveness of the tablet is very good when it is taken early, and it is having the over-the-counter availability also. So it is not a regular use tablet, it is a one-time tablet or twice a tablet we are taking. When it is splitting into 0.75 and 0.75, it is taking in the alternative manner. So that is the case in this. And the additional components I would add to you is Okay. Yes. So next we are coming into the oral contraceptive pills. Oral contraceptive pills or oral combined pills. Like OCP is like this OCP type. The name itself it is explaining that it is an oral combined pill because it is the combination of both progesterone and estrogen. So this is a very common drug which is used in your National Family Planning Program, that is your Mala N and Mala D. So it is very important to note what is Mala N. The composition of Mala N and Mala D is asked in all the competitive examinations. As you know, Mala N, the combination is your ethylene estridiol, okay, ethylene estridiol 0.03 mg plus your levonorgestrel 0.15 mg. Your ethylene estridiol 0.03 mg plus your levonorgestrel 0.15 mg is the combination of Mala N, and it is same for Mala D also. Same combination is for Mala N as well as Mala D. The important point you have to note in community health nursing perspective is the special features. It is supplied free of cost by Government of India. Mala N is supplied free of cost in Government of India, whereas Mala D, it is delivered by ASHA workers to the homes itself. So this is the important point you have to note in Mala N and Mala D. Okay. So next, so this is the important point you have to note, and the one more thing you have to note is the composition. The pack composition is also asked in the examination. Your Mala N and Mala D both are going to have 28 tablets. Both are going to have 28 tablets. In those 28 tablets, 21 tablets or white tablets. 21 tablets or white tablets that are hormonal pill. The hormonal pill is in the composition of your ethylene estradiol and levonorgestrel. So both are synthetic. Ethylene estradiol is a synthetic estrogen. Okay, ethylene estradiol is synthetic. It is a synthetic estrogen. Whereas your levonorgestrel is your synthetic progesterone. So you have to note these 21 hormonal tablets, white tablets, or the combination of your ethylene estradiol and levonorgestrel, that is the synthetic estrogen and synthetic progesterone. Then the rest of the 7 tablets or iron tablets, these are brown tablets. So these are brown tablets, and the composition of the particular tablet is ferrous fumarate. Right? So this is the important point you have to note in this particular slide. So now we have covered all the basic important concepts which is governing your family planning drugs. Right? Yes, Antara is asked, and it is a repeated question. That's why you will never know like in which part they are finding the question. They can ask about the dosage. They can ask about the number of tablets. They can ask about the composition. They can ask about the advantage. They can ask about the contraindications. So these are very important point to note, right? So that's why I have explained all these into short form concise tables to make it more clear. So next we will go to the MCQ part, right? So now, as you people are watching the classes for this much time, you will be very much known that what is the answer for this MCQ. Now tell me, which of the following intrauterine device has the lowest failure rate? Now tell me, what is the lowest failure rate among all the contraceptive methods listed below? Now tell me, which of the following intrauterine device has the lowest contraceptive failure rate in the given options? Just tell me. Your progestrate or your copper T380A, your Marina or your copper T200. I'm waiting for your answers. Answers. Just tell me what is the correct answer for this particular MCQ. Which of the following intrauterine device has the lowest failure rate among the contraceptive methods listed below? So you are having the options progesterate, copper T380A, Mirena and copper T200. What is the correct answer? The correct answer is Mirena. As you all know, Mirena has the least failure rate. This is the third generation contraceptive device. Okay, this is the third generation contraceptive device. Third generation intrauterine contraceptive device. Okay, intrauterine contraceptive device, and the failure rate of this is 0.3 per 100 women. Per 100 women. So this is the most important component. You have to know the lowest failure rate is your Mirena. Lowest failure rate is for your Mirena. So for copper progesterate, copper T380A and copper T200 comparatively, which is having the lowest failure rate is your Mirena. So next, so which of the following is the absolute contraindication to intrauterine device insertion? Now tell me a very important question you have to note, like which of the following intrauterine device, okay, which of the following is an absolute contraindication of the intrauterine device insertion? So now we are going to learn about the contraindications, the absolute contraindications of intrauterine devices. Now tell me if you know the answers, you can tell me. Like, the absolute contraindications for intrauterine devices. First is your undiagnosed vaginal bleeding. Undiagnosed vaginal bleeding. Okay, it can be anything, menorrhagia, metrorrhagia, anything that is undiagnosed vaginal bleeding. The second most absolute contraindication, is disordered uterus. Disordered uterus, which includes cervical cancer, uterine cancer, okay, cervical cancer, uterine cancer, uterine anomaly, everything is an absolute contraindication of your intrauterine device. So the third most absolute contraindication is pelvic inflammatory disease. When the patient has an active pelvic inflammatory disease, that is the absolute contraindication. Okay, when the patient is having active pelvic inflammatory disease, that is an absolute contraindication. On contradictory, you have to also know, on contradictory, when the patient is having the history of pelvic inflammatory disease, this is not the contraindication. This is not the contraindication for the insertion of IUCD. But if the patient is having active pelvic inflammatory disease, that is the contraindication for administration of intrauterine contraceptive devices. So the fourth one is suspected pregnancy. If the patient is suspected pregnancy, then that is also going to be the additional important absolute contraindication. So first you have to note the undiagnosed vaginal bleeding, that may be abnormal uterine bleeding, menorrhagia, metrorrhagia, or any other condition which causes undiagnosed uterine bleeding, fibroid uterus, endometriosis. So in these cases you are not at all going to insert intrauterine device. Next is disordered uterus, any anomaly or any structural malformation of the uterus. In those cases also you are not going to give intrauterine devices, though it is absolutely absolutely contraindicated. Next, we have active pelvic inflammatory disease. When the patient is a case of active pelvic inflammatory disease, that is also an important contraindication, like absolute contraindication. When the patient is having active pelvic inflammatory disease, this is going to further worsen up the condition, so you are not going to give the intrauterine devices. Next is suspected pregnancy. When they are suspecting pregnancy, that is also an absolute contraindication for administration of intrauterine devices. Now, the one more thing you have to note is these all are common. These are common absolute contraindication. These are common absolute contraindication for both second and third generation. Right. Now we are going to specifically see about certain things. For copper T, okay, for copper T, okay, for copper T, okay, again the fifth contraindication you are going to see, this is very specific to copper T and Mirena. Okay, this is very specific to copper T and Mirena. So your IUCD, okay, your IUCD, that is your intrauterine contraceptive device, specifically your copper T, that is the second generation, okay, second generation. So the absolute contraindication very specific to this copper T, that is like better to write it as copper T, it is Wilson's disease. It is Wilson's disease. It is Wilson's disease. What is Wilson's disease? As you all know, what is Wilson's disease? Wilson's disease is the genetic disease in which the copper cannot be eliminated properly by the body, so the copper will be settling inside the liver and other major organs. So that is termed as Wilson disease. Since the copper T is going to have copper, so the metabolization of the copper will be quite inefficient if the patient is a case of Wilson disease. So if the patient is a case of Wilson disease, copper T administration is absolutely contraindicated. So this particular Wilson's disease is an absolute contraindication only for copper T. Right. On the other hand, we also have an additional absolute contraindication for another intrauterine device, that is your Mirena. That is 6 is your Mirena. For Mirena, if the patient is a case of breast cancer, if the patient is a case or having the history of breast cancer, you are not going to administer Mirena. You are not going to administer Mirena. So very, very important point to note. So first, this is common for both second and third generation. Undiagnosed vaginal bleeding, disordered uterus, active pelvic inflammatory disease and suspected pregnancy, all are a very common absolute contraindication for both second and third generation. But specific to the device, we have the 5 and 6. If we talk about IUDs, that is your copper T, Wilson's disease is the absolute contraindication. On the other hand, for Mirena, history of breast cancer is the contraindication which you have to note, right? So now tell me, which of the following is an absolute contraindication to intrauterine device insertion? Just tell me, as I said you before itself, like history of ectopic pregnancy is not an absolute contraindication. If the patient having the failure of intrauterine contraceptive devices, then only the patient will go for ectopic pregnancy. But if the patient is having history of contraceptive devices, history of ectopic pregnancy, no, that is not an absolute contraindication for the administration of IUDs. Next, suspected pregnancy. Yes, as you can see here, suspected pregnancy is an absolute contraindication for intrauterine devices. So this is the correct answer. Next, copper allergy. Copper allergy is a relative contraindication but not an absolute contraindication. It is a relative contraindication. Nulliparity is not an absolute contraindication. So in case of nulliparity also copper T is administered in some cases. Right. So I hope this question is clear. Which of the following is an absolute contraindication to intrauterine devices? It is suspected pregnancy. Whenever you find a question on intrauterine device contraindication, you have to remember these six are the important absolute contraindications. So first and foremost, you have to remember undiagnosed vaginal bleeding, disordered uterus, active pelvic inflammatory disease, and suspected pregnancy. These are common for both second and third generation, whereas when the patient is a case of Wilson's disease, insertion of copper T is contraindicated. Next, if the patient is having the history of breast cancer, then insertion of Mirena is contraindicated. Right, children? Yes. So now next we will move to the next question. So Mala D, a commonly used oral contraceptive in India, is best described as. Now tell me, Mala D is a commonly used oral contraceptive device in India is best described. It is an emergency contraception containing high dose of levonorgestrel. No, it is not only having levonorgestrel, it is also having estrogen. Right. So that is a wrong statement. And a combined oral contraceptive pill provided through government supply. Yes, it is a combined oral contraceptive pill. As you all know, it is containing estrogen plus progesterone. So that's why it is termed as combined pill. Oral combined contraceptive pill. So that is the correct answer. Next we will see a progesterone only pill used in lactating women. Yes, the most important point you can learn from this option is progesterone only pill or used in lactating women. Progesterone only pill or used in lactating women. Please excuse me. Excuse me, Ashish. Yes. Sorry for the interruption. So I said you from the option C, the most important point you have to note in exam point of view is the progesterone only pill is used in lactating women. The progesterone only pill is used in lactating women. This is the correct statement, but it is not respective to Mala D. Okay, this is the correct statement, but it is not respective to Mala D. The progesterone only pill is used to lactating women. Why? Because progesterone has no effect on breastfeeding. Okay, when the mother is breastfeeding, progesterone only pill can be administered because it is not going to have any effect. Either it is not going to increase, either it is not going to decrease the breast milk. So it is very safe to administer progesterone only pill. When we are talking about estrogen, when you are giving OCP, that is combined pill. Combined pill which is containing estrogen is not administered in case if the mother is breastfeeding, because estrogen has the direct effect, to decrease the breast milk secretion. So it has the effect to decrease the breast milk secretion. That's why for lactating women we are not going to give estrogen related pill, estrogen having combined pill. Right. So next is an intrauterine hormonal device used for 5 years. So what is the intrauterine hormonal device which is used for 5 years? Now let's recap. You have to tell me which of the intrauterine device which is used for 5 years. Tell me. Which of the intrauterine device is used for 5 years? Yes. You have to remember your copper T375 multi-load is used for 5 years. Again, if you are going to see, the Mirena is also used for 5 years. The lifespan of your copper T375 multi-load and Mirena is 5 years. So I will be writing here so that you will be having your copper T375 multi-load and your Mirena is also having 5 years. So which is having 10 years? Your copper T375 380A, right? Yes. Now we will go to the next question. Sorry. So many people were asking me like what is the contraceptive of choice. This is also a very very important point, MCQ point. So now we are going to learn like what is a contraceptive of choice. As I said, breastfeeding female, as I said you, progesterone is not having any effect on breastfeeding, so we are going to give progesterone only pill for breastfeeding females. So anytime after delivery for breastfeeding females, we are going to give progesterone only pill. Progesterone only pill. Right. So next, Antara, that is your DMPA. As we discussed earlier, your Antara should be given after 6 weeks for breastfeeding females. Next, oral combined pill after 6 months only. Oral combined pill after 6 months. Why oral combined pill after 6 months? Because it after exclusive breastfeeding, we are going to give oral combined pills. Okay, in order to promote breastfeeding. Right? Next, in non-lactating females, Antara anytime after delivery, because Antara, as you all know, it is having selective estrogen modulator, right? Selective estrogen receptor modulator. So it has an effect towards breastfeeding, like breast milk production. So for non-lactating females, you can give it any time after the delivery. But for breastfeeding females, you have to give only 6 weeks. Okay, only 6 weeks. Next, OCP after 3 weeks. Oral combined pills you can give after 3 weeks. Next, in all female regardless of lactation, you can give intrauterine contraceptive device within 48 hours of after 6 weeks of delivery. Within 48 hours, that is your what kind of insertion? Intrapartum insertion, and after 6 weeks of delivery, it is interval insertion. As you know, this is intrapartum. Okay, this is postpartum, postpartum insertion. We know that we have post-placental insertion, that is after 10 minutes of delivery of the placenta. This after within 48 hours, that is after 10 minutes to within 48 hours, it is postpartum insertion of the IUCD, and after 6 weeks, that is what? Interval insertion. So that is done for all females. That is the choice of contraception in case of any female regardless of their lactation. Next, female sterilization, that is the permanent method of sterilization we are doing, female sterilization within 1 week or after 6 weeks, and emergency contraception after 4 weeks we are going to give for any female who is regardless of their lactating possibilities. For unmarried female who is having active sex or intermittently they are living far away from each other. So in this case, what we are going to do, barrier method plus oral combined pill we are going to use. So to delay the first childbirth, obviously we are going to go for oral combined pills with intrauterine contraceptive devices. Next, to delay the second child, spacing method. For spacing method, what we are using? First we are using intrauterine contraceptive devices, then we are going for OCP. When comparing to oral combined pills, intrauterine contraceptive devices is used first when in case of spacing, when they want a space between the first child and the second child. Okay, IUCD is preferred for longer spacing when comparing to your oral contraceptive pill. Next, occasional meeting or married couples, here we are going to use intrauterine contraceptive devices. So it prevents any form of accidental pregnancies in case of long distance relationship also. So this is very very important table you have to note in your clinical point of view. So we are going to the next question. Under Pradhan Mantri Jan Arogya Yojana, what is the maximal annual health insurance coverage provided to each beneficiary family? So this is also a very important and repeated question. Now tell me, what is the maximal annual health insurance which is given under your Pradhan Mantri Jan Arogya Yojana? As you all know, it is 5 lakhs. It is 5 lakhs is the current 5 lakhs is the correct answer. So this particular program is generally popularly termed as your Ayushman Bharat. This Ayushman Bharat is targeting 50 crore families. Okay, sorry, 10 crore families. 10 crore family Okay, so if it is targeting 10 crore family, it targets 50 crore individuals. It targets 50 crore individuals, right? So under Pradhan Mantri Arogya Yojana, okay, it is under Ayushman, it is popularly known as your Ayushman Bharat. So the annual health insurance, maximum health insurance which is given is 5 lakhs, right? Then you have to note the target audience they are targeting is 10 crore families, which means it is targeting 50 crore individuals, right? So this is the important point you have to note. And image based questions you can have, this is the logo of your Pradhan Mantri Jan Arogya Yojana, okay, Ayushman Bharat. Next, so this is e-health portals. They can ask you direct questions in MSc entrance examination. They can ask you like what is e-Sanjeevani, what is e-Raktakosh, so like that they can ask the question. So it is very important to note this also, so that's why I have put up this particular slide, okay. Yes, so first is e-hospital. E-hospital is for hospital record maintenance and OPD registrations and appointment scheduling. As you all know, e-hospital is for hospital electronic health record maintenance. Next is e-Sanjeevani. E-Sanjeevani is for telemedicine services, doctor to patient, doctor to doctor consultation. When you think about e-Sanjeevani, you think about telecommunication, like telemedicine. You think about telemedicine. E-Raktakosh, as the name implies, it is talking about the National Blood Bank Management System. As it is talking about e-Raktakosh, so it is talking about National Blood Bank Management System. Next we have EVIN, that is your Electronic Vaccine Intelligence Network. As the name implies, it is for monitoring the cold chain and logistic management of the vaccines. Next we have Kilkari. Kilkari is sending voice messages to pregnant women and mother for immunization reminders. So what will happen, these kind of programs will improve the quality of community health care which is given to the people. So in order to promote the health care, they are receiving in the community setup, even in the rural population, these particular programs has been evolved. So for example, Kilkari, like if a woman is not educated properly, so she is not having a proper idea about how to give immunization for her child, right? How to give the basic care. So this particular Kilkari will be effectively used for them to come up and know about the immunization, their schedules, and when they have to immunize their children, right? So that is the aim of these particular e-portals, e-health portals. Next we have NHP, that is National Health Portal. That is a centralized portal where you can find all the health related informations, like all the programs which is available, all the welfare schemes, all the important updates, if there is any breakdown, if there is any incidents, or if there is any prevalence, all kind of data. What about the updates which is related to the Ministry of Health and Family Welfare or Ministry of Health, you can find in this website. Next we have Mira Hospital. Mira Hospital means My Hospital, as you all know. So collect patients' feedback, tracks OPD usage, and improve hospital services in case of government sectors and then private sectors. Next is M Diabetes, as the name implies, it spreads awareness and information regarding diabetes prevention and control. It spreads awareness and information regarding the diabetes prevention and control. So it is going to give reminders like when you have to go to take the medication, when you're going to go for checkup, when you're going to monitor your blood glucose, everything will be monitored by your M Diabetes. Next is M Cessation. M Cessation helps the users to quit smoking and tobacco through mobile-based support. M Cessation, as the name implies, M Cessation is the app that is going to actively use in your quitting the smoking for people who are the chronic chain smokers. Next, as you all know, Nixia, a commonly asked question. Nixia is the e-health portal for TB case tracking and ensuring anti-TB drug compliances. Okay, like whether the patient is taking the drugs properly or not, because TB drugs are more prone for the resistance, so we are having direct observation dots technique, right? So to reinforce this, the Nikshaya e-health platform is there. Next we have Nikshut. Nikshut is for leprosy. Nikshaya is for TB. Nikshut is for leprosy. Okay, don't confuse yourself. Nikshaya is for TB. Nikshut is for leprosy tracking. Okay, Nikshaya is for TB tracking. Nikshut is for leprosy tracking. So now we will go to the next question. So which of the following e-health portals is specifically designed for providing telemedicine consultation? As I said to you, I reinforce the word telemedicine consultation. It is e-Sanjeevani. It is e-Sanjeevani. As you all know, e-hospital is for monitoring the e-health records. Nikshaya is for TB tracking and medication administration of TB patient. Mera Hospital is to collect the OPD details, feedback mechanism of the patient in government and private hospitals. Right? So we'll go to the next question. Which of the following is true regarding the mother's absolute affection scheme? So the mother's absolute affection scheme. So here in community, there is a lot of chances you will be getting more questions from the healthcare programs, from the logos, okay, from the important concepts which is noted, right? So it is very important to know about these schemes. So now tell me, which of the following statement is true regarding mother's absolute affection scheme, shortly known as MAA scheme? So it promotes institutional delivery in rural areas. No, it is not. The name is not specifying in some case. It provides cash incentives to mother after delivery. No, it is not going to provide any cash incentives. But you can able to test, use your common sense and think under what program that the first option will come. It promotes institutional delivery in rural areas. It is coming under Janani Suraksha Yojana. It is coming under Janani Suraksha Yojana. Suraksha Yojana. Janani Suraksha Yojana. It is coming under Janani Suraksha Yojana. It is coming under your Janani Suraksha Yojana. Right. So it promotes yearly initiation of exclusive breastfeeding. Just remember, whenever you think about Ma means mother. Right. Ma means mother. That is the short form of your mother's absolute affection scheme. So Ma means mother. This scheme is concentrating. The objective of the scheme is to promote yearly initiation. This scheme is to promote yearly initiation of early initiation of exclusive breastfeeding for the child, for the child, right? It is implemented by Ministry of Women and Child Development. No, it is not introduced by the Ministry of Women and Child Development. So now we have a quick recap about what is coming under your Ma. So this is the logo of your Ma, right? So as I said to you, it is not coming under This is not coming under your Ministry of Women and Child Development, that is your Mother's Absolute Affection Scheme, is not coming under your Ministry of Women and Child Development, but it is coming under your Ministry of Health and Family Welfare. But it is mimicking that it might come under that department, but it is actually coming under, it is launched under the Mother Absolute Affection Scheme, is launched under Ministry of Health and Family Welfare, right? So next, it is not under Ministry of Women and Child Development. So it is aimed at promoting breastfeeding, exclusive breastfeeding, and awareness among mothers and caregiver about its importance of breastfeeding, right? The scheme emphasizes initiating breastfeeding within 1 hour for birth of normal deliveries, know the timing, and within 4 hours for cesarean deliveries. They can specifically ask you about the timings also, like at what hours the breastfeeding has to be initiated under MA scheme, that is your Mother's Absolute Affection Scheme, right? So you have to remember, in case of normal delivery, it is going to be after 1 hour, immediately after 1 hour. In case of your cesarean delivery, it is going to be within 4 hours, right? So they are going to talk about exclusive breastfeeding. As you all know, exclusive breastfeeding is a very important component and very important advice as a nurse you have to give, as a community health nurse, as a general nurse, general practicing nurse, you have to give to the patient. So the most important point is it is promoting first 6 month exclusive breastfeeding for the child, right? It is reinforcing this. So next question. So as I said the first component initiation of institutional delivery was under Janani Suraksha Yojana. The option A was implementing. So as I said it promotes institutional delivery, and based upon this promotion of institutional delivery in the rural population, the ASHA will be receiving the cash incentives, not only the ASHA but also the women. So they might be asking questions on the amount of cash incentives the ASHA or the mother is getting on this. So that's why I have put this slide, right? So in case of rural area, if under Janani Suraksha Yojana, if the mother is coming for institutional delivery, she will be awarded 1,400. ASHA will be awarded 600 rupees as an incentive. So this LPS means low performing states and HPS means high performing states. So in case of urban area, it is going to be 1,400 for ASHA. In case of rural highly performing states, it is 700 for the mother and 600 for ASHA. And for urban high performing states, it's 600 for the mother and 400 for the ASHA. And this is the logo of Janani Suraksha Yojana. Janani Suraksha Yojana scheme, so that also you have to remember. So you can get image based questions also. So next, the most important another scheme and the most repeated questions also in all the NORCET examination aims like these questions. So that's why I have compiled these questions and put under this, right? So here you have to remember Lakshya scheme, okay? The Labor Room Quality Improvement Initiative, Lakshya is the scheme. This is the logo of that scheme. This is basically the objective of the scheme is to ensure safe, respectful childbirth services, okay, safe and respectful childbirth and midwifery services to the women, to the antenatal mother who is coming for the childbirth, right? It focuses on the labor rooms infrastructure, infection control and training of the staffs inside. So Lakshya scheme is basically concentrating on the labor rooms infrastructure, training of the personnel who is working under the labor room and the infection control of the labor room. And it is very important for you people to note the logo of this Lakshya scheme. Okay, the logo of the Lakshya scheme, it is having a kick mark that the infrastructure and safety of the mother in the labor room is going to kick start. So you can remember this, okay, the targeted kick start. So next we have the next question, which of the following vaccine is most commonly associated with the risk of interception if administered after 6 months of age? Vaccine and immunization based questions is also very common when they want to put question under community health nursing, right? So community health nursing is also an important component under your preparation for your MSc Entrance examination. So MCQs regarding immunization, vaccination, open vial policies, everything is very common in your examination. So it is very important to note. As I said you, my dear children who is preparing for MSc Entrance examination, you will be getting memory based MCQs rather than analysis based MCQs. You're not going to get any critical thinking MCQs, big scenarios, nothing. You're going to get straight one shot questions which is going to be memory based. If you are thorough with the theoretical concepts, you can definitely kick your examination, right? So prepare well with your plan MSc 5.0, utilize the maximal things, attend the live session. All the important questions are discussed in the live session so that you will have a better clarity for your examination. Okay, coming back to the question. So which of the following vaccine is most commonly associated with the risk of interception if administered after 6 months of age? If it is administered after 6 months of age, a very important component. I'm just waiting for you people to answer for this question. Okay, answer for this question. As I said you, if this particular vaccine is administered after 6 months, so what is the which patient can get risk of interception? So it is proved that rotavirus vaccination, if it is administered after 6 months of age, please note it, after 6 months of age, it has a minimal risk of causing interception. So when your rota vaccination is administered, So it is administered in 6 weeks, 10 week and 14 week. Okay, in 6 week rota 1 is administered. Rota 1 is administered. In 10 weeks, Rota 2 is administered. In 14th week, Rota 3 is administered. Rota 3 is administered. Okay, so it is very important to know that which particular vaccine is having the risk, minimal risk associated with interception is your rotavirus, right? And one more thing you have to note is what are the other complications of the vaccines. So this table I have put it for you. So BCG, your Bacillus calmette-guerin, which is given for prevention of your tuberculosis, causes scar formation, as you all know, and lymphadenitis is the common side effect of BCG administration, BCG vaccine administration. Next, in oral polio vaccine administration, vaccine associated paralytic polio, which means the patient will be getting flaccid paralysis after administration. Because why it is happening is, in case of this oral polio vaccination, okay, this inactivated vaccine, what will happen, because of its neurovirulence, it can cause paralytic, it can possess paralytic properties and causes flaccid paralysis. So that is termed as your vaccine associated paralytic polio, which is the associated common side effect when after administration of the oral polio vaccine. So the patient will be getting flaccid paralysis because of the increased neurovirulence because of that inactivated component. Okay, so next is pentavalent. So what are the components which is coming under pentavalent? As you all know, DPT, that is your diphtheria, pertussis and tetanus, and Hib, that is your Haemophilus influenza vaccine, and your hepatitis B. Hepatitis B is coming under your pentavalent vaccination. Your diphtheria, pertussis, tetanus, Haemophilus influenza and your hepatitis B are coming under your pentavalent vaccination. That is the 5 vaccination, right? 5 vaccines are coming under your pentavalent vaccination. As you all know, what is this common side effect which is associated with the pentavalent vaccination is inconsolable cry. The inconsolable cry also will be greater than 3 hours. Will be greater than 3 hours. Because the child will have intolerable cry greater than 3 hours. And neurological irritability will be also there. Among this all pentavalent vaccine, if they are asking what is a specific vaccine which is under this pentavalent vaccine is going to cause this inconsolable crying and neurological irritability, the important drug which is hiding inside pentavalent vaccine, which is causing this common side effect of inconsolable cry and neurological irritability is pertussis. It is pertussis. So pertussis is the most specific drug which is going to cause this kind of intolerable effects of intolerable cry and so on. Okay, so the pertussis component is the one which is going to cause this, right? Next we have rotavirus. As we seen, when it is administered greater than 6 months of age, and we have seen rotavirus is administered in 6 weeks, 10 weeks and 14 weeks, and if it is administered greater than 6 months of age, it has the risk of causing interception in the minimal aspect. Next we have MR vaccine, that is measles and rubella. It causes measles like rashes, the most common question, every children will be knowing it. Measles like rashes for 5 to 7 days after vaccination. Next we have tetanus and diphtheria. So it causes brachial neuritis, which causes the shoulder and upper arm pain. Okay, so this is all about the vaccine and their common side effects. So next question is, which of the following vaccine uses normal saline as a diluent for reconstitution? So before discussing this question, it is very important to note what is meant by reconstitution. What is meant by reconstitution? So what is meant by reconstitution, dear children? Reconstitution means certain dry freezed vaccine. Okay, dry freezed vaccines, certain dry freezed vaccines. These dry freezed vaccines, what it will do, okay, these vaccines are like in the powder format. They are in the powder format. They are in the powder format. They are in the powder form. So for administration of these vaccines, what is essential for administration of these vaccines has to be liquefied, right? This has to be diluted with some important components which is specific to that, some important dilutants which is specific to that, and it has to be made into liquid form, and it is ready for the administration to the patient, administered to the children. So that process is called reconstitution. Reconstitution is the process where the dry freezed powder form medication, powder form vaccine is diluted with their specific dilutant and which is kept ready for the administration, then it is administered to the patient, right? So here they are asking about which of the following vaccine is used for normal saline. Normal saline as a dilutant. So normal saline is used as a dilutant to reconstitute BCG vaccine. A very, very, very important point to note. BCG vaccine used normal saline for reconstitution. BCG vaccine used normal saline for reconstitution. Okay. So next we have measles and rubella, Japanese encephalitis, and JE killed. So now we are going to learn what are these vaccine dilutants respectively. As I said you, BCG is freeze dried. Okay, BCG is freeze dried. It is a live attenuated vaccine. You are going to use normal saline. Measles and rubella, it is also freeze dried. It is also freeze dried, live attenuated, and we are going to use distilled water. Remember, BCG NS. BCG, Bacillus calmette guerii, it is normal saline, whereas measles and rubella you are going to use distilled water. Then you have JE live. JE live vaccine. JE live vaccine is also freeze dried. Is also freeze dried, and it is also a live attenuated vaccine which is going to be diluted with phosphate buffer. A very, very important point to note. BCG we are going to use normal saline for reconstitution. Measles and rubella we are going to use distilled water for reconstitution, and JE live vaccine we are going to use phosphate buffer for reconstitution, right? And JE killed vaccine, it is already in the liquefied format. It is an inactivated and killed format. No dilutant is required for this killed vaccine. Okay. So now coming back to the question, now for measles and rubella, it is distilled water. It is distilled water. And now tell me what is for Japanese encephalitis live. For Japanese encephalitis live, it is phosphate buffer. It is phosphate buffer. And what is for killed vaccine, JE killed vaccine? No dilutant is required. No dilutant is required. I hope this answer is clear. Now we will go to the next question. So which of the following vaccine is not covered? Here I have given you like capital letter presentations so that it will be very easy for you to understand. Okay, very easy for you to identify. Either they are asking not factor, expect factor, or something like that. But this is not the same case in your examination. They won't give it highlighted. Okay, you should not expect these things, right? So that what is the important tip you have to notice? You have to read the question properly. First read the stem of the question, then come for the options. If you're not going to read the stem and you're going to directly read the options, what is going to happen, children? You're going to waste the time. Right. So first clearly read the stem of the question. Don't miss any word. Any word can be the keyword. You can miss not. You can miss except. So highlighting these words, and if you miss these words, you're going to lose the marks. Right. So first try to concentrate on the stem of the question. So which of the following vaccine is not covered under open vial policy and must be discarded after 4 hours of opening? What is meant by open vial policy? As you all know, what is open vial policy? Open vial policy is a policy introduced by the government in order to absolute objective is in order to reduce the vaccine wastage. Reduce vaccine wastage. Okay, reduce the vaccine wastage. So it is advising the vaccine will be used till 28 days from the opening. Okay, from the opening, 28 days from the opening. So they might ask the dates also. Okay, the days also. 28 days from the opening. It is not one like that after till 28 days you can use, but with proper maintenance. With proper maintenance of cold chain. With proper maintenance of cold chain. With proper maintenance of cold chain. With the proper maintenance of cold chain. So this is the component. Open vial policy is launched by our government in order to reduce the vaccine wastage, because when the vaccine is having multiple doses after administration in one particular setting, in one particular day, this vaccine, what they will do, they will process into the cold chain after opening the vaccine also. If there is multiple doses which is left inside the vaccine vial, so we are going to place it under the cold chain, and we are going to reuse this vaccine with a proper cold chain monitoring. So these vaccines can be used for 28 days, and there is a limitation for that. Certain vaccines cannot be used under this particular component. As we learned about reconstitution, the vaccines which are reconstituted, such as your BCG vaccine, your measles and rubella, what vaccines we are seeing? Measles and rubella and your BCG vaccines are not administered after 4 to 6 hours after it is reconstituted, right? They are not eligible for open vial policy. Open vial policy eligible for drugs except your BCG and your measles and rubella. Okay, now we are coming back to the question, like which of the following vaccine is not covered under open vial policy? As I said you, and must be discarded 4 hours of opening. Okay, and you have to remember, as I said you, measles rubella vaccine, as I said you, it is coming under reconstitution, where you are going to dilute it with the respective dilutant, and this vaccine has to be used within 4 to 6 hours from after reconstitution. Right, it should be discarded after that. The effect will be lost, or it may become it is not that much efficient when it is left for open vial policy. So this is very important point to remember. Whereas DPT, hepatitis B and tetanus toxoid are eligible for your open vial policy. So what is the another vaccine which is not eligible? If BCG is there, you are going to take BCG also. And Japanese encephalitis live is also not coming under your open vial policy. You have to note this. Like 3 vaccines, like your measles, rubella, BCG, and your Japanese encephalitis live, not killed, live, will not come under open vial policy, right? So the all rest vaccines are coming under your open vial policy, where we can use it for 28 days after opening when we are monitoring proper cold chain to that particular vaccine, right? So here is a detailed talk up regarding this. As I said you, valid up to 28 days, and BCG is used 4 to 6 hours after reconstitution, and the wastage factor you can note in the slide. Wastage factor of BCG is 2, and for measles and rubella it has to be monitored, it has to be administered, used within 4 to 6 hours, and the wastage factor is 1.3 noted. So rotavirus, yes, an additional information you have to notice. Rotavirus, the old product has came with a vaccine vial monitor on the cap. Okay, vaccine vial monitor on the cap. Okay, now it is not applicable for the open vial policy. But the new product, the rotavirus vial, which is, sorry, I am drawing the vial in a very bad manner, but TK, but you will remember it, right? If I do something like this. Okay, So here the vaccine viral monitor is placed in the body of that particular product. Okay, new rotavirus virals are having vaccine viral monitor in the body, and now the vaccine viral monitor is on the label that is mentioned it is in the body, so it is eligible for open viral policy. So the new regimen is rotavirus is also eligible for the open viral policy. So the presentation of that particular drug is different. Earlier it is on the cap, now it is on the body. The vaccine viral monitor is on the body. So which of the following diagnostic test is considered as the investigation of choice for confirming the diagnosis of tuberculosis? So they are asking specifically the confirmation of the confirming for the diagnosis of tuberculosis is done by with diagnostic method. So sputum microscopy for acid-fast bacilli, it is not a confirmatory diagnostic test. Chest x-ray, when you are suspecting, you are going for chest x-ray, but it is not a confirmatory. CBNAT, yes, your cartridge based nucleic acid amplification test. This is the expansion of CBNAT, that is your cartridge based nucleic acid amplification test. Okay, that is the confirmatory test for tuberculosis. We will see in detail in next slide. Then line probe assay. Line probe assay is also not a confirmatory test, so that CBNAT is the correct answer. So here we will have the diagnostic modalities of TB. First is the chest x-ray. Chest x-ray, screening or suspicion. Okay, if you are suspecting the patient may have the tuberculosis, so we are going for chest x-ray. Next, limitation is it is not specific and it is not a confirmatory diagnostic tool. So it gives immediate report and you can visualize the chest x-ray. Next is acid-fast bacilli microscopy. It is the investigation of choice for screening purpose, not for confirmatory purpose. So that too you have some limitations, like you have some important nursing considerations while talking about your acid-fast bacilli microscopy. The most important component is the maximum amount of sputum sample you have to collect from the patient is 5 ml sputum. Right, and it is collected in two forms, sample A and sample B. Sample A is collected at the time of you meet the patient, at the time of admission, okay, immediately after you suspect the patient. Sample B is early morning sample. Early morning sample. Yeah, early morning sample, right? So it is low sensitivity to HIV patients and extrapulmonary TB patients. So acid-fast bacilli microscopy is not used. And what is the strain which is used? It is Zeal-Nielsen strain, you have to note. And the report will be, time of the report will be 30 minutes to 24 hours. Next we have CBNAT, that is cartridge based nucleic acid amplification test. So investigation of choice for confirmation, also it is used in screening for patient who is living with HIV. So in HIV, whereas as I said you, acid-fast bacilli is not so specific when the patient is an active case of HIV, but in case of patient is having HIV, also we can able to find with the help of CBNAT. It will be the confirmatory test for your tuberculosis. So high cost in some areas and 90 minutes the test findings will be released. And next we have TrueNAT, that is true nucleic acid amplification test. This was found by India. Okay, this is more common in India also. It is affordable, faster than CBNAT, still gaining widespread use, and it is 60 minutes when comparing to CBNAT. Next we have LPA, that is your line probe assay. That is your line probe assay. So line probe assay, so drug resistant profile like rifampicin resistance can be monitored with line probe assay and not a primary diagnostic tool. It is for drug resistant rifampicin specific components. So the result will be for 2 to 7 days. Next we have culture. In culture, LJ media will be used. Just remember these things. Here it is Zeal-Nielsen, either here it is Zeal-Nielsen training, okay, and here it is LJ media, you have to remember, right? It is a gold standard but slow, especially a solid culture, and it takes 2 to 7 days for the report, so it is not a confirmatory test. So which of the following is the investigation of choice for diagnosing malaria under National Vector-Borne Disease Control Program? So under Now we are talking investigation of choice. Keyword for diagnosing malaria, another keyword under National Vector-Borne Disease Control Program. So three components you have under this particular program, which is the following investigation of choice to diagnose malaria. As you all know, the gold standard investigation of choice for diagnosing malaria is peripheral blood smear. Peripheral blood smear. Okay, so now let's see the what is the component behind peripheral blood smear. So thick smear used to detect the presence of malarial parasite. In thick smear we are just finding, in peripheral blood smear, in thick smear we are just finding whether whether malarial parasite is present or not. Next we have thin smear. In thin smear only we are coming up to the conclusion whether what species is especially present, what species is specifically present, either it is Plasmodium falciparum or ovale or what, vivax, everything will be identified in thin smear only. So this differentiation is also you have to remember. This differentiation also you have to remember. Next, strains used is Jashwant Singh Bhattacharya strain. Okay, the strain used is your Jashwant Singh Bhattacharya strain or Jimsa strain. Okay, Jimsa strain. And high specificity and sensitivity under proper microscopic examination is present in this peripheral blood smear. That's why we are getting, that is the investigation of choice. Important investigation of choice. So another additional components you have to know is Plasmodium vivax. When they can ask the most common species of malaria in India, it is Plasmodium vivax. And the common in northeastern states, it is Plasmodium falciparum. Absent in India, not present in India, it is your Plasmodium ovale. Then less common is Plasmodium malariae. Most common in India is vivax, less common is malaria. So Plasmodium knowlesi, it is the rarest and seen in Indonesia and Vietnam only. So next, important dates you have to remember. So first is World Malaria Day, it is 25th April. It is 25th April. Just now it is passed. Anti-malaria month is June. Anti-malaria month is June. National Dengue Day is 16th May. National Dengue Day is 16th May. And Anti-Dengue month is July. Anti-Dengue month is July. Anti-malaria month is June and July. Malaria first, dengue next. Malaria is June, dengue is July. Then World Neglected Tropical Disease Day is 30th Jan, covers 21 diseases, right? World Neglected Tropical Disease Day is 30th Jan. So Malaria Day is 25th April and dengue is 16th May, and anti-malarial month is June, anti-dengue month is July, right? Please remember these memory-based questions. Identify the following scheme. Now tell me, this particular logo is representing which scheme? As it is clearly Mission Indradhanush, you will be having a kit. Anemia Mukti Bharat, something related to blood you will be having. Poshan Abhinay, yes. Poshan Abhinay is the correct answer because already you have seen PM Matru Vandana Yojana's logo, right? So this particular scheme, the correct answer is Poshan Abhinay. It is a nutrition based program. Okay, so now let's see what is Poshan Abhinay. This is Poshan Abhinay's logo. So Poshan Abhinay stands for Prime Minister's overarching scheme for holistic nourishment. Prime Minister's overarching scheme for holistic nourishment, which is launched in 2018. Okay, it is under Ministry of Women and Child Development, and the focus area is to reduce anemia, is to reduce the low birth weight by 2% per year and 3% per year for anemia, and improvement for nutritional status for child under 0 to 6 years, adolescents and pregnant and lactating women. It is also integrated with the National Nutrition Mission. Just remember Poshan. So they have given tree-like component which indicates growth. So they are basically concentrating on the nutritional development in combination with National Nutritional Mission. So you can remember in such a way. Next, so this is Intrauterine. This is the logo for Intrauterine, Mission Intrauterine. As you know, it is an immunization specific national health program. As you all know, here they are reinforcing about immunization, right? So here you have to remember the 2024 update of Mission Intrauterine, that is intensified Mission Intrauterine, that is IMI 5.0, that is intensified Mission Intrauterine 5.0. So what are the updates is rotavirus vaccines open vial policy has been added, which we have discussed so detailedly, and third dose of FIPV, that is your fractionated IPV. Okay, fractionated IPV was been newly launched in 2024, which is administered in 9th month, which is administered in 9th month. Which is administered in the 9th month, as you all know. And the next important thing is JE killed vaccine was introduced. JE killed vaccine was introduced. Okay. And this is the Anemia Mukt Bharat's logo. As you all know, like Anemia Mukt Bharat schemes intensified information has been discussed in the last class, as you all know. This is the logo for this, and this is PM Matru Vandana Yojana. As I said you, PM Matru Vandana Yojana's logo is this, and this is specifically concentrating on women and child development, which was launched in 2024. That is 2.0, an update was being launched, and the incentives are structured. Like for the first child, 5,000 rupees in 2 installations is given to the mother. If the second child, only if the child is a girl, promoting female child reproduction, so it is 6,000 rupees. So in the installments which include registration plus antenatal care within 6 months, first 3,000 she will be getting. In the second installation, childbirth plus first vaccination, which includes your BCG, OPV, DPT and your hepatitis B, 2,000 she will be getting. So this is PM Matru Vandana Yojana in order to promote the health and nutrition of the antenatal mother, right? So the incentives related data also you have to remember. Screening for hypertension to prevent complications like stroke and kidney diseases is an example for which level of prevention. Screening or preventing complication, this is the keyword you have to note. So when we are talking about screening for hypertension, preventing of complication, you have to directly go and take secondary. Secondary prevention is only talking about your screening, yearly diagnosis and all components, right? So now we are going to see in detail, so that you can able to understand the keyword. First is primordial prevention is basically for preventing the risk factors. Primordial is for preventing the risk factors. So which includes lifestyle modification, health education, sanitation, and safe water. Lifestyle modification, health education, sanitation, everything. When the question is on lifestyle modification, health education, when it is targeting on preventing the risk factors, then you are going to definitely go and take primordial. So in case of primary, it is preventing the disease. It is used in order to prevent the disease. Disease prevention is different and complication prevention is different. So disease prevention is done by primary only. Disease prevention is done by primary only. So immunization, pre-employment checkup, pre-exposure prophylaxis, food fortification, everything is coming under primary prevention. Secondary prevention, as the question implies, prevention of complication. How the complication can be prevented? Early screening, early diagnosis and prompt treatment and management, where you can prevent the complications. Next we have tertiary. Once everything is happened, when you are helpless, in this case we are going for tertiary prevention, that is disability and death. In order to prevent the further disability and death, we are going for tertiary prevention. Here disability limitation, rehabilitation processes, organ transplantation and all the rehabilitation processes are coming under your tertiary prevention. I hope you will not forget tertiary prevention, but there will be always confusion in primordial, primary and secondary. Primordial, always remember prevention of risk factor, any health education before it is coming. Okay, to prevent the risk of that occurrence, we are giving this primordial. Primary is once the disease, in order to prevent the disease, they are exposed and the disease is going to come. So in order to prevent the diseases, whatever the management we are doing, that is coming under primary. On secondary, in order to prevent the complications which is relating to that, we are going for the secondary prevention. Right? So which a worker from a textile industry present with a chronic cough, and note the textile industry, and she is having chronic cough and shortness of breath, which of the following is the most likely diagnosis? As you have to know, when the patient is working, when a particular woman is working in a textile industry, for which particular disease she is more prone to, that is your biocinosis. Cotton industries are related to your biocinosis. Okay, textile industries are related to biocinosis. Anthracosis and bagosis and asbestosis. Okay, anthracosis is because of the asbestos, and bagosis is because of the anthracosis is because of the, like we will see in the upcoming slide. Anthracosis is because of the coal dust. Okay, it is because of the coal dust. It is because of the coal dust. Whereas your bagosis, you can remember sugar cane. Okay, you can remember sugar cane, and this asbestosis is because of the asbestos dust. Right. So to have a clear picture, silicosis, the particle which is causing silicosis is silica, and sandones, granite, pottery, ceramic, coal, mica and steel industries, patient will be getting silicosis. Asbestosis, as I said, it is because of asbestosis. Asbestosis, cement factories, fireproof textile industries causes asbestosis. Anthracosis is because of the coal dust. So you can remember silica, silicosis, asbestos, asbestosis, anthracosis, you can remember the CO, that is coal dust, and biocinosis, you can remember cotton. Okay, cotton dust. Biocinosis, you can remember cotton. Okay, so this NO you can remember as ON, like cotton, and bagosis, that is sugarcane. You have S, right? So that is sugarcane dust, right? Next we have the last question. Which of the following parameters is exclusively metallic and it is used in the assessment of air quality index? The National Pollution Control Society will be monitoring this air quality index. Here they are asking you specifically which of the following parameter is exclusively metallic. So other components are not metallic, but this is metallic. As the name implies, the answer will be lead. So why there is a justification? So particular matters like your particular matters with have 2.5 micrometers and 10 micrometers. These are particles like 2.5 micromilli. These particular components will get inside the lungs, and bloodstream. Will get inside the lung and bloodstream. Whereas your particular matters of 10 micrometer. Sorry. Yes. So the particular matters with 10 micrometer, they can get into the lower respiratory tract. Okay. So this is talking about mu m. Mu m means micrometer. Micrometer. Okay. Then nitrogen dioxide, it is a gaseous pollutant. Sulfur dioxide, gaseous pollutants. Carbon monoxide is a gaseous pollutant. Ozone is a gaseous pollutant. Ammonia NH3 is a gaseous pollutant. Lead is a only metallic component which is assessed in the AQI, that is the air quality index. Smoke is a composition of fine particles and all, right? So particle matters which is 2.5 in micrometer, they are getting into the lung and bloodstream, and whereas it is 10, if it is 10, it can enter the lower respiratory tract. And the air quality grading scale, sometimes they can also put the question in there because these are memory based questions. So when it is less than 100, it is good. When it is greater than 200, it is poor. when it is greater than 400, it is very severely poor. So this is the component here. This is the component here, and we will discuss about the nursing management MCQs in the next class. Okay, we will discuss the nursing management MCQs in the next class. Okay, so I hope this video was really helpful and informative for you people, and if you have any doubts, you can contact me through my Instagram handle, social media handle. And thank you so much for watching. All the very best for your AIIMS MSc entrance examination. Thank you, children.